meeting. We are very busy today. We have a busy agenda, and I just want to let everyone know that if you're interested in testifying, there's a sign-up sheet. I am going to be trying to consolidate the testimony, so if you are here with a group and you're basically testifying on the same issue, if you can find a spokesperson, that would be helpful. Please be mindful of the time and the testimony. I'll remind you as we go along kind of where we are on time. Of course, there are no signs or permitted in the committee, and decorum is expected of everyone in the room. And I would just ask that everyone please silence your phones. So with that, we will go ahead and call the roll, Madam Secretary.
Representative Bentley,
Yes, ma'am, here in the room.
Representative Bowling, Representative Bray,
Present in the room.
Representative Birch, Representative Dotson,
Present in the room.
Representative Elliott, Representative Fleming,
Present in the room.
Representative Frazier Gordon,
Present in the room.
Representative Marzian, Representative Gibbons Prunty,
Here in the room.
Representative Rayburn,
Here in the room.
Representative Raymond,
I'm here.
Representative Riley, Representative Sharp,
Here.
Representative Sheldon,
Here.
Representative Tate, Representative Weber, Representative Westrom, Representative Wilner,
Here in the room.
Chairwoman Mosier.
I am here. We have a quorum established and are ready to do business, so we will jump right in. I know that we have some folks who are having to go between state government and this committee. I believe Senator Douglas has a bill to present in state government as well, so we'll go ahead and take up Senate Bill 55. Welcome, Senator Douglas, and please introduce yourself for the record and your guest, and proceed.
Thank you, Madam Chairman, and good afternoon to the committee. I'm Senator Douglas, District 22, Jessamine County, as well as Garrett County and part of Fayette County. With me today is Ms. Shannon Smith. She's with the American Heart Association, and she is here to help answer any questions that you all may come up with. I'm here today to discuss Senate Bill 55. It's what I call the System of Care Bill regarding strokes. The bill defines and further categorizes the different levels of stroke centers that we have in our great Commonwealth. It will help you better understand the different levels of care that are available to our stroke victims. Previously, we referred to stroke centers as just primary stroke centers. One of the reasons for this bill is that a primary stroke center is now a category. So if we talk about a primary stroke center, we want you to know that you're talking about a particular category and not just a general term. We've also added a thrombectomy capable center as now one of the 4 categories of stroke centers. Why thrombectomy capable? Because again, different hospitals offer different levels of care. It has always been thought that, well, our hospitals offer the same levels of care, and I assure you they do not. Early in my career as a physician, I worked as an emergency room physician, and it was pretty scary, some of the things that came into my emergency rooms that should have gone to other centers.
Motion on the bill.
Second.
We have a motion and a second on the bill. Thank you for that expedient explanation. And do we have any questions? All right, seeing none, Secretary, please take the roll.
Representative Bentley,
Yes, ma'am.
Representative Bowling, Representative Bray,
Yes.
Representative Birch, Representative Dotson,
Yes.
Representative Elliott,
Aye.
Representative Fleming,
Aye.
Representative Frazier Gordon,
Yes.
Representative Marzian, Representative Gibbons Prunty,
Yes.
Representative Rayburn,
Yes.
Representative Raymond,
Yes.
Representative Riley, Representative Sharp,
Aye.
Representative Sheldon,
Yes.
Representative Tate, Representative Weber,
Yes.
Representative Westrom, Representative Wilner,
Yes.
Chairwoman Mosier.
Yes, ma'am. Okay. Senate Bill 55 passes unanimously, and the same should pass on the House floor. Congratulations, and thank you very much for this great legislation.
Thank you so much, Madam Chair, and thank you to the committee.
Absolutely. Okay. Next, we will take up, actually, you know what? I think while we have a quorum and we have members going back and forth, I'd like to go ahead and consider the regs that we have. Everyone should have received all of the links to the regs, and I would just like to consider those reviewed. Are there any questions from the committee? All right. We have a motion and a second. All in favor of accepting the regs? Aye. Okay, thank you. All right, next. I see Senator Alvarado in the back of the room. And so we will go ahead and take up Senate Joint Resolution 72. Please introduce yourself for the record and proceed.
Thank you,
for
Madam
being
Chair. Ralph Alvarado, State Senator for the 28th District.
Steve Shannon with the Association of 11 Mental Health Centers, CARP.
Thank you all for considering Senate Joint Resolution 72. It's fairly self-explanatory. For those of you who may or may not be aware, we had an opportunity to have a severe mental illness task force this past year. I heard a lot of very good testimony from dozens of individuals and institutions who are trying to find ways to help better deliver care to people with severe mental illness. This is a product of that task force, had several recommendations. The first recommendation was to help set up a severe mental illness waiver for the state of Kentucky, and this would direct the cabinet to apply for a Medicaid waiver for individuals with severe mental illness.
Motion on the bill.
Second.
Hang on just one moment, please. We have a sub to adopt. We need a motion. Thank you. Motion and second on the sub. All in favor?
Aye.
Any opposed? Thank you. We do now have a motion and a second on the resolution. Are there any questions or comments? All right. Seeing none, Madam Secretary, please take the roll.
Representative Bentley?
Yes, ma'am.
Representative Bowling? Representative Bray?
Yes.
Representative Birch? Representative Dotson?
Yes.
Representative Elliott? Representative Fleming?
Aye.
Representative Fraser Gordon?
Yes.
Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn?
Yes.
Representative Raymond?
Yes.
Representative Riley?
Yes.
Representative Sharp?
Aye.
Representative Sheldon?
Yes.
Representative Tate? Representative Weber?
Yes.
Representative Westrom? Representative Wilner?
Briefly explain my vote.
Yes, ma'am.
Thank you. Senator Alvarado, thank you so much for this resolution. And as you mentioned, the SMI task force, that was the place to be during the interim. We've done such really amazing work that we've seen come out of that. And we had almost an entire meeting devoted to the problem of supported housing for people with SMI and how the lack of supported housing takes a toll not just on individuals and their families and their loved ones, but entire communities. So this is a really important resolution, and I just want to thank you for it. Yes.
Chairwoman Mosier?
Yes, ma'am. Senate Joint Resolution 72 passes as amended by the committee sub. The same should pass on the House. Congratulations, and thanks very much for your work.
Thank you, Madam Chair. Members of the committee, model of efficiency. I appreciate it. Thank you.
Thank you so much. Okay, next we will call up Senate Bill 10. We have with us Senator Robbie Mills and any guests that you may have with you, and we do have a committee sub.
Motion on sub.
Yes, ma'am.
We have a motion and a second on the sub. All in favor?
You're welcome.
Any opposed? Thank you.
Very good.
All right, please proceed.
Thank you, Chair Mosier and committee. Today I bring to you Senate Bill 10. Senate Bill 10 addresses several statutory issues that I believe could be holding back nurse availability in Kentucky. We've been very intentional with this bill over the last several weeks. We've welcomed input from every angle, and all interested partners have listened and to and we've listened to them, and they've offered suggestions and changes. We've received valuable input from Kentucky Board of Nursing, all of our nursing schools, hospitals, and long-term care providers. Senate Bill 10 addresses three areas, and I'm going to summarize these three areas of concern. First of all, Senate Bill 10 improves the process for out-of-state and foreign-trained nurses to practice in Kentucky without compromising our standard of care. The idea of these changes are to allow qualified nurses to get to work in Kentucky faster and to remove any red tape that could possibly be slowing down their licensure. The second thing that it does is Senate Bill 10 improves access to nursing programs by removing enrollment limitations placed upon our nursing programs, once again without compromising the quality of education and training provided by our nursing programs. If the criteria is met for them, these programs are able to self-determine the size of their enrollment every year. The third thing Senate Bill 10 does is make updates to the Kentucky Board of Nursing's membership by adding term limitations, changing it to 12 years. It adds geographic requirements, so it's going to require at least 2 representatives from each congressional district, and it also adds Senate confirmation to these appointees. I believe these are very practical updates to Kentucky's nursing oversight process, and I believe we'll see these changes produce positive results in the very near future and help fill this huge nursing gap that we all know that we have in the Commonwealth. At this time, I will let my guest introduce herself and explain about the committee sub that you just adopted.
Good afternoon. Turn that on. Good afternoon, members of the committee, and thank you for allowing me to speak today in favor of the Senate Bill 10 House Committee substitute. My name is Jennifer Wiseman, and I am the current president of the Kentucky Association of Nurse Anesthetists. I represent over 1,200 CRNAs practicing here in Kentucky, and we comprise 2/3 of the state's anesthesia providers. We practice in every single county in the Commonwealth where anesthesia services are offered. The Senate Bill 10 House Committee sub further amends KRS 314.121, the statute that dictates the composition of the Kentucky Board of Nursing, as you've just heard. Senate Bill 10 aims to address parts of the multifactorial critical nursing shortage we are experiencing here in Kentucky. As part of our professional association's due diligence, we analyzed Senate Bill 10 as well as the current composition of the Kentucky Board of Nursing and discovered another key area that should be addressed. Senate Bill 10 highlights a structural deficiency within the Board of Nursing composition, being there's no statutory requirement right now for geographical representation within our Board of Nursing.
Motion on the bill.
Second.
Thank you. We have a motion and a second on the bill, and I just want to personally thank you for this, like you said, very practical legislation in addressing our immediate crisis with the healthcare worker and certainly nursing shortage. And thank you, Ms. Wiseman, for being here. Sure. I appreciate the addition with the committee sub. We do have a question from Representative Wilner.
Thank you, Madam Chair. I like almost everything in this bill. The Senate confirmation of members of the nursing board. Is there any other health professions licensing board that requires Senate confirmation?
I'm not aware of any, no.
May I continue? Thank you. I'm really concerned about this. And, I used to work for the Psychological Association as a psychologist. I know that none of the mental health licensing boards have this requirement. And it worries me that political appointments, there are political appointments to these boards, but having another layer of politics involved in getting people on these boards really concerns me a lot. And I guess since we have a committee sub anyway, and this isn't, going through clean, right. Would you be willing to look at an amendment and to, consider an amendment that gets rid of just that provision and changes nothing?
I probably would not, but of course it's in the House's hands, and y'all can amend however you need to and want to. But, you know, one of our focuses was elevating nurses, practicing nurses' voices in the Commonwealth, and that's probably one of the reasons that we decided to put the confirmation on there, is to assure that the balance in the board remains working nurses focused, and not it doesn't get heavy again, top heavy again with nurse educators and things of that nature. So that was my thought process. Once again, we talked to several folks, had a lot of input on it, and this is the first question that I've had about, you know, concerns about the appointment process. So it's in the House, and y'all can amend as you see need, but I don't see a need for that.
One quick follow-up, if I may.
Quick.
Very quick. Thank you for the response. I appreciate it. I just wonder what would happen if there was a vacancy on the board and there needed to be an appointment made when the legislature is not in session, which is, of course, most of the year. So would they have to wait 10 months?
Yeah, I believe they'd have to wait. And once again, it is a larger board, so it's not going to cause that big of a malfunction in the board, such as like the PSC or something like that, that just has a few members. So I don't see any problem with that.
Thank you.
Representative Raymond?
Thank you. Jennifer, Representative Marzian wanted to send a special hello to you. I wanted to ask you all to quantify these solutions for us as best you can. We hear about the nursing shortage. If you would tell us again how large that shortage is, and then if there are educated guesses or projections over 1 year or 5 years for, you know, welcoming nurses from other states, what will that bring us? Welcoming nurses from other countries, what would that?
I've seen numbers just in the last few months talking about this and having folks visit in my office, expecting, you know, 12,000 to 16,000 nurses shortage, practicing nurses, LPNs, RNs, and things of that nature. That's the number that I have been told coming. Right now, to be honest with you, what started me down this road was several months. I got a call from somebody that manages a long-term care facility. I mean, they're just dying for folks, RNs and LPNs, to be there to supervise. And it's a major problem in that sector for sure. So,
Sure, and I can speak the numbers that I don't have them right here in front of me because I wasn't prepared to speak on those numbers today, but they're the same numbers that you've heard from the Kentucky Nurses
Is your
Association.
microphone on?
It is.
Okay.
Sorry.
Thank you.
I'll get closer. The numbers that I would speak to regarding the nursing shortage are the same numbers coming out of the Kentucky Nurses Association related to licensure. What I was focusing on, like he said, to make a strong board focused on practicing nurses and not getting heavy in the education aspects of it. Our licensure has tremendously changed number-wise over the past 22 years, which is the last time that our board composition was addressed in statute. At that time, in the year 2000, it was added an RN seat. So I don't have specific numbers, but I do think moving forward with creating a strong regulatory body that is familiar and capable and in the know of what is happening with practicing nurses in this state is very important. And I can tell you the nursing shortage is real. While there's no shortage of nurse anesthetists in this state, I see firsthand when I'm at work looking at operating rooms that can't function or surgeries that can't go on because there is not the nursing manpower to hold those patients, you know, for an elective procedure. That's the way I see it in my specialty, but I think this is great moving forward, creating a board that's representative of the current number of licensees and those actually practicing.
Yeah, thank you all.
For sure.
I just think we need to have projections, right? Removing that student enrollment cap, is that going to get us a couple hundred nurses or a couple thousand? And if we could have projections on each of these components, we would know if we're going to wait for this to work or if we're still looking for solutions.
yeah, I mean, I think the biggest issue is just getting folks engaged back in nursing. I mean, that's the first step. Taking the caps off is maybe something that may help 2 or 3 years down the road. But right now, I think we just got to encourage folks to get back in the nursing field and get our classes filled up as much as possible.
And I don't have those numbers. Those are, I think those have been discussed several times so far this session from the Kentucky Nurses Association. They're really leading and the whole Team Kentucky Task Force, they have all those numbers and they're being discussed, but I personally do not have those numbers in front of me as far as projections.
Okay, thank you.
Okay, thank you. Representative Birch, did you have a question?
Yes, I do. Thank you, Madam Chair. Has this board already been established?
The Kentucky Board of Nursing, yes, it's
I
established.
mean,
yes.
the board is going to be dealing with this, the ones that's going to have to be certified by the Senate.
Yes, it's in practice right now.
Oh,
yes.
okay.
Uh-huh.
Thank you, Madam Chair.
Thank you. Okay, seeing no further questions, Madam Secretary, please take the roll.
Representative Bentley?
Yes, ma'am.
Representative Bowling? Representative Bray?
Yes.
Representative Birch?
Yes.
Representative Dotson?
Yes.
Representative Elliott? Representative Fleming?
Quick comment. Thank you. I vote aye, and I appreciate Ms. Wiseman coming to me and keeping me up to date for the past about a month or so, and really educating me on this. And I appreciate you working with the senator, and Senator, thank you for working with her and expanding this, and appreciate y'all's effort. And hope this really comes to fruition. I vote aye.
Representative Frazier Gordon? Yes. Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn?
Yes.
Representative Raymond?
Yes.
Representative Riley? Yes. Representative Sharp?
Aye.
Representative Sheldon? Yes. Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom? Representative Wilner?
Yes.
Chairwoman Mosier?
Yes, ma'am.
Madam Chair,
Yes.
before we close the voting, may I record a yes vote on Senate Bill 10?
Yes, please.
Thank you.
Yes, we've got you. Representative Tate just had to run out. Okay, we'll get her recorded votes on other bills later. Okay, Senate Bill 10, as amended by the committee sub, passes with favorable expression. The same should pass on the House. Thank you very much for bringing this, and congratulations.
Thank you. Thank you, Madam Chair and Committee. Thank you.
Next, we will take up House Bill 336.
Madam Chair, may I record a yes votes on Senate Bill 55 and Senate Joint Resolution 72?
Yes, sir.
Thank you.
Yeah, absolutely. No, absolutely. Yep.
Okay, please introduce yourselves for the record and proceed.
I'm Representative Deanna Frazier Gordon, District 81 in Madison County.
Hi, I'm Andrew Rutherford. I am the Government
Will you
Affairs.
pull your microphone a little closer and make sure that it's
ma'am.
on? Thank
Okay.
you. Is the light on?
Yes, ma'am.
Okay.
Andrew Rutherford. I am Chairman of the Government Affairs Committee for the Kentucky Academy of Physician Assistants.
Okay, thank you. We do have a committee sub.
Move we adopt.
Second.
We have a motion and a second. All in favor? Aye. Any opposed? Okay, thank you.
Thank you, Chair Moser and members of the committee. Physician's assistants are a significant part of Kentucky's healthcare delivery system in all aspects of patient care. Physician assistants in Kentucky continue to value their role in the physician-led team model and consistently work with the Kentucky Medical Association and other stakeholders to find ways to improve patient care and lower the administrative burden on healthcare providers. House Bill 336 reflects the result of some of that work. The goal is to simply update a few components of the licensure statute to better reflect modern standards of practice. With me today is Andrew Rutherford of the Kentucky Academy of Physicians Assistants to explain the changes and answer any questions.
Motion on the bill.
Okay, we have a motion and a second. Mr. Rutherford, is there anything that you would like to quickly add?
No, ma'am. I'm here to answer any questions if needed.
He's a smart man. Okay, do we have any questions from the committee? All right, seeing none, Secretary, please take the roll.
Representative Bentley?
Yes, ma'am.
Representative Bowling? Representative Bray?
Yes.
Representative Birch?
Yes.
Representative Dotson?
Yes.
Representative Elliott? Representative Fleming?
Aye.
Representative Frazier Gordon?
Yes.
Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn?
Yes.
Representative Raymond?
Yes.
Representative Riley? Representative Sharp?
Aye.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom? Representative Wilner?
Yes.
Chairwoman Mosier?
Yes, ma'am. Okay. Oh, Representative Tate, would you like to record some votes?
Yes, please. I'd like to record a yes vote for SB 55 and SJR 72.
Thank you.
Thank you.
Okay, so House Bill 336, as amended by the committee sub, passes with favorable expression, and the same should pass on the House. Thank you. I will make my way to the table and hand over the gavel to my co-chair. You know what? I'll do loan forgiveness first.
Okay. We're going to take up House Bill 573. Representative Moser, please take your seat, and any guests, and proceed.
Thank you, Madam Chair. Thank you, committee, for giving us the opportunity to discuss this really important piece of legislation, House Bill 573. I am Representative Kim Mosier of the 64th District, for the record, and I'll allow my guest.
Good morning. I am Fran Feltner, the Director of the Center of Excellence in Rural Health.
Okay. Thank you so much. All right. 573 addresses the healthcare worker shortage and establishes a much-needed recruitment and retention tool for program for healthcare workers in rural and underserved areas in Kentucky. It immediately addresses the access to care issue and healthcare worker shortage with a long-term solution. This will, again, aid in recruitment and retention of our healthcare professionals and keep them in Kentucky. The program will be established within the UK Center for Excellence and for Rural Health alongside an existing federal program. The mission of the Center for Excellence in Rural Health shall be to improve the health of all rural Kentuckians and the improvement of the healthcare systems through education, research, and service. This is very much in keeping with what we are trying to do here. This program would supplement the federal funding by accepting state dollars, grants, and private donations.
Motion on the bill.
We have a motion on the bill and a second. Any questions? Representative Wilner?
Thank you, Madam Chair. I'm just full of questions today. Just wanted to, so you mentioned rural and urban parts of the state as well.
Mm-hmm.
So would that also be included in the supplement?
Yes, there is a framework in place through the Kentucky Office of Rural Health that Dr. Feltner can probably describe and discuss it more in depth, but they have an assessment needs framework, and I'm not sure if you want to elaborate.
We do assessments to see where the folks that come to us for aid with financial matches for their state loans that they have when they come out, which they're really high in debt. And we do look at those areas. It doesn't matter if it is urban or if it is rural. If it is a needed area, we are obligated to help them.
Thank you very much.
You're welcome.
Representative Birch?
Thank you. What is the problem of retaining these people? Is it wages, working conditions? You really have to be a dedicated person to do this, and I know it's almost like a vocation, but what do you pay these people in order there has to be some factor that keeps them from doing, staying in the field if they get burned out or what is the problem?
If you want me to. Mm-hmm. Sometimes what happens to our primary care providers is they are offered higher paying jobs, or they are offered to pay their loans to help them. When they come out of school at first, whether they're a physician, whether they're a nurse practitioner, they have a really high debt load, and they're going to go where they can get the best pay in order to do that. If we can do these loan repayments for them, it not only helps recruit them to our areas, it helps with their debt, and it helps us with keeping them there. There's an obligation for them to stay when we do this loan repayment program.
Okay, thank you.
And I would just add that when we are able to recruit and retain through a loan forgiveness program, some of our healthcare workers, especially, and this incidentally adds to the list of healthcare worker professionals or healthcare professionals who are currently eligible for scholarships. This expands this. So it's not just doctors, it's nurses, APRNs, dentists, therapists, and audiologists, ophthalmologist, and so forth. So we are looking to expand this. But once an individual moves to an area, they get established with their family. And if we can recruit individuals to these underserved areas, they're more likely to stay once they become part of the community.
Representative Westrom?
You don't need to answer this question today, but it might be interesting to get an update on what's happening with our osteopathic school and what the rates have been for people who have trained here and come back to work here. Thank you.
Okay, well, thank you very much for that question or comment. I incidentally have a whole list of information from the Osteopathic School of Medicine, College of Osteopathic Medicine in Pikeville. And they do outline some of the barriers that they face. And they identify scholarships as very helpful. And I mean, I'm happy to share this with you, but they do kind of outline some of their situation. And they would be included in this.
Great. It'd be interesting to know what the numbers are as far as retention in the state upon graduation. Thank you.
I have the applicants who applied for this scholarship and loan forgiveness program, and there were 19 MDs and DOs who did not get a loan repayment simply because they did not meet the eligibility, or probably the funding wasn't available. And so this would expand that. And this, just expands the reach of this program, and it's completely dependent upon the funds that are in this trust.
Representative Birch?
I do understand these, and I wrestled with this thing for over 30 years. When these people get jobs and get their profession perfected, they're going to move where the money is. Now, in the rural areas where they roll up the sidewalks at 6 o'clock at night, the schools are not good or they're poor. And how do you keep them there in that area? Because we're going to be wrestling with this problem again 30 years from now. And there'll be people sitting on both sides of this arguing this, but there has to be something that, some people that live there and grew up there will stay there in most cases. But in most cases, when somebody finishes medical school or nursing school, they may go to work there for a while because you got an incentive to keep them there. But once that time is up, they're going to move. There has to be something more to keep them there.
I don't disagree that we need economic development in across all of our Commonwealth. And certainly when a physician or an APRN takes up practice in a rural area, they become an employer. Mm-hmm. And so those are jobs that were not available otherwise. And so, this is a piece of a very big puzzle. We don't have a one answer. So it's multifactorial, and I do appreciate your comments.
Representative Rayburn.
Yes, could you tell me what the cost that this is going to, what will the impact on the budget be with this bill?
The appropriation request is $2 million, and I haven't seen it in the budget yet. I'm not sure that this is really even enough to recruit all of the workers that we need in these underserved areas to really bolster the economy in these underserved populations. But the appropriation is $2 million right now. And we also are setting up a trust fund that can accept grants and private donations. So it's not just the state appropriation.
Thank you.
Representative Tate.
Thank you, Madam Chairman. So, Representative Mosier, I appreciate you bringing this to us. So is that a $2 million appropriation on an annual basis, or is there like a sunset to this, or what's the plan?
Right now, it's an annual $2 million appropriation. And, I certainly would expect that if we completely solve our healthcare worker shortage, that we wouldn't need this anymore. So I'd love to work ourselves out of this job.
There being no further questions, Madam Secretary, please take the roll.
Representative Bentley?
It's one of the greatest things for that part of the country, and thank you, Dr. Filtner, for your dedication. I vote yes.
Representative Bowling? Representative Bray?
Yes, explain my vote, please. This is awesome for my part of the state. I vote yes, and just for the record, I'd put my schools up against any in the state, so thank you all.
Representative Birch?
Yes.
Representative Dotson?
Yes.
Representative Elliott? Representative Fleming?
Aye.
Representative Frazier Gordon?
Yes.
Representative Marzian? Representative Gibbons Prunty?
I'm going to briefly explain my vote. Representative Birch, Senator Meredith would tell you that there are disparities in the reimbursements from rural areas to urban areas, and so we need to work on that. So my vote yes, thank you very much for this. It's very needed.
Representative Rayburn?
Briefly explain my vote. I'm going to pass for today. I have several more questions about this program and how it would work. Thank you.
Okay. Representative Raymond?
Yes.
Representative Riley?
May I explain my vote?
Yes, sir.
I want to reiterate what Representative Bray said. Schools in rural Kentucky do an excellent job. I vote yes.
Representative Sharp?
Aye.
Representative Sheldon?
Absolutely yes.
Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom?
Quick comment. Thank you for bringing this very important piece of legislation before us. I vote yes.
Representative Wilner?
Yes, and quick comment, I hope we get the $2 million appropriation into the budget. Thank you for this.
Chairwoman Mosier?
Yes.
House Bill 573 passes favorably and should do so on the House. Congratulations, and we'll now take up House Bill 604. Any guests are coming to the table for 604? And
Thank you.
introduce yourselves for the record and proceed.
Yes, ma'am. Thank you, Madam Chair. I am Representative Kim Mosier once again for the record, and I have with me Mr. Bart Harden.
Bart Harden, Director of Government Relations, University of Kentucky.
Okay, and Representative, you have a committee sub. Would you like to?
I do have a committee sub.
Would you like to have a motion?
Second.
Do we have a second? Second. We have a motion and a second on the sub. We may proceed.
Thank you. And also online, we have Dr. Shanna Babylonis with us, who has very graciously agreed to be with us to help explain what we are doing here. And I just want to especially thank you for allowing me to interrupt your maternity leave. And I want to congratulate you on the birth of your daughter, Dr. Babylonis. Thank you for being with us.
Thank you so much.
Thank you. So what we are talking about today is House Bill 604, and it simply establishes the Kentucky Center for Research, Cannabis Research at the University of Kentucky. I have had this bill before you previously, and the purpose is to advance the study of marijuana and cannabis derivatives for the treatment of certain medical conditions as recommended by the Board of Directors. The board will be made up of stakeholders, healthcare professionals, and researchers in one organized center. I believe that this really will put Kentucky in a leadership role concerning research in and around the cannabis issue. This board, this research center, will carefully review and monitor current and future literature, establish and increase clinical trials, and study the outcomes of states with marijuana programs. the increase in clinical trials and the expediting, I can say this, of research in Kentucky for the treatment of certain medical conditions is of utmost importance when we're talking about cannabis derivatives. UK, and my guests can better explain this, but UK does already have research. They have a strong connection to the FDA, but this simply convenes all of the researchers from around the state and allows more research to happen. The committee sub would expand the application process, open it more publicly, and allow individuals who were interested in participating to apply and to, of course, be screened, assessed, and placed into the appropriate clinical trial. I think at this point I will just turn it over to my guest for a few comments, and certainly am available to answer any questions.
Thank you, Representative Moser. We appreciate you bringing this bill again. As you indicated, for the record, I think this is our third time with this bill. We appreciate it. It's obviously a research center that'll be multidisciplinary across campus. And with that, I'm going to let Dr. Babylonis say a few words about this bill. Thank you.
Sure. I'm Shana Babylonis. I'm an assistant professor in the College of Medicine at the University of Kentucky. And this research center would be a huge game changer for Kentucky, and it would also spur research that would help everyone throughout the nation. So there are very limited institutions in the United States right now that have the permissions and the Schedule I licensing to administer cannabis in a clinical trial to humans. So very few states and very few researchers have these permissions. University of Kentucky and myself, we have those right now, but we're limited. It's a bottleneck because those processes to obtain all those regulatory permissions are very burdensome. And so if we would get a center with focused individuals who are all working towards the same goal, we could expand the number of people who have those regulatory permissions. We could expand the amount of research that we do, and we could really make a difference, I think, to try to figure out what conditions can we treat with medical cannabis.
Motion on the bill.
Second. I have a motion and a second. Any further discussion? Any questions? Dr. Bentley, Representative Bentley.
I've supported this for 3 years, and I think it's the best approach to the therapeutics of medical marijuana. Thank you, Kim, for bringing it back, and thank you, Kay, for being willing to speak about it.
Representative Raymond.
Thank you. Might this hamper the legislature's ability to approve medicinal marijuana prior to research conducted here?
There's nothing in this legislation that would preclude or hamper the efforts of a medicinal marijuana program being implemented. In fact, there's language in this bill that says that should Kentucky implement a medical marijuana program, that individuals who apply for a medical card in that program would also be eligible or be given the opportunity to participate in research. So no, they can coexist. I believe that the way that some states, Mississippi comes to mind, has rolled out their medicinal marijuana program is really prudent and smart. They started with research in 1964 through the cultivation center that they have. And in fact, I added that language to this bill to have the center apply for, through the DEA or NIDA, for a license for a cultivation center in Kentucky. I think that, this is a very strong way to control the research and to really hone in on the properties that we need to research. So it in no way hampers those efforts.
Thank you. One follow-up, please.
Go ahead.
How would it interact with federal research?
Dr. Babylonis, can you answer that?
I can. I think it would really help our federal grant dollars. So I get grants from the National Institute on Drug Abuse. And so that's the federal research that's being conducted is through grantees like myself. And so I think that this would give us a huge opportunity to apply for more grants and get more grant funding in Kentucky.
Thank you.
Any other further questions? Madam Secretary, please call the roll.
Representative Bentley?
Yes, ma'am.
Representative Bowling? Representative Bray?
Yes.
Representative Birch?
Yes.
Representative Dotson?
Yes.
Representative Elliott?
Aye.
Representative Fleming? Representative Frazier Gordon? Representative Marzian? Representative Gibbons Prunty?
I'm going to briefly explain my vote. You have the cart and the horse. I think this is the horse, so thank you. I vote yes.
Representative Rayburn?
Yes.
Representative Raymond?
Yes.
Representative Riley? Yes. Representative Sharp?
Aye.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom? Representative Wilner?
Yes.
Chairwoman Mosier?
Yes, ma'am.
House Bill 604 is amended by Committee Sub 1. It passes with favorable expression and should do so on the same. So congratulations.
Thank you so much.
Now we'll take up House Bill 457. As the chairwoman makes her way back, you can take your place away.
Madam
Mr.
Chair, may I?
Representative.
May I
Yes, you
record
may.
some yes votes?
Yes.
I'd vote yes on House Bill 336, House Bill 573, yes, and House Bill 604, yes.
Okay, just please go ahead and introduce yourselves for the record, and please proceed.
Steve Sheldon, representative from District 17, and I'll let my guests introduce themselves.
Danny Bentley, District 98, the great Commonwealth of Kentucky.
Kathy. President of the Kentucky Pharmacists Association.
I'm Jim Musser. I'm the Vice President for Policy and Government Relations with the Kentucky Hospital Association.
Okay, if we'll get started here, we're obviously going to be here. The name of our House Bill 457. It's related to pharmacy and pharmacy services. Do want to mention briefly how the sub changes, and we'll adopt that sub because I think the fact that the sub has changed, I think in a way that would tackle some of the concerns of maybe some of the folks that are here. So
Okay, we need to adopt the
Motion to
committee
sub.
sub. We
Yeah.
have a motion and a second. All in favor?
Aye.
Okay, and yes, thank you for starting with the committee sub. Just go ahead and explain any changes and
Appreciate that.
and proceed.
and we'll move. I've scratched a lot of it. I know how much time we have, but we'll get going here. In the sub, we really took away all pricing language when it came to pricing thresholds, and that was some of the issue. Dispensing fees came out. The NADAC floor language came out. Pass-through pricing requirement came out. Even there was some mention in one of the fiscal notes, early fiscal notes, that the Benefit Management Advisory Council for pharmacy would cost a little money. We took it out because we already have a TAC council, so we thought that would be okay. And then we added some PSAO language that would require fiduciary duty to pharmacies to match the fiduciary duty that PBMs owe to insurers. So those are the things that I believe will address a lot of what any opposition would have as far as worried about the cost of this. And this is truly about consumers, and we'll move forward. Let me say just a couple quick things, and then Kathy's going to read 2 or 3 minutes, and then I'll highlight some stuff, and we'll be ready for questions. We've got about 15 to 20 entire organizations over the last 3 years are supporting this bill and continue to support today. You have a list of them probably in your folder. This has been 3 years of a collaboration that it's just everybody working together. We even had an informal work group this last summer that involved several representatives, several senators, again, just to get to this bill. I do want to say I'm a legislator, I'm a pharmacist. I serve as a division CEO for a very large self-insured company with several thousand employees, so I'm very sensitive to that issue and how this could affect that. I'm convinced I'm doing what's right for every single one of those. And unfortunately, I am also a consumer as of late with some issues that you got, health issues. So I feel like this addresses all four. And I'm very proud of this bill. All of you all have watched this thing evolve over the last few years. I appreciate everybody's support. I do plan to continue working with those four and maybe some in opposition today beyond this, and look forward to move together. And at this, I'm going to relinquish it to Ms. Kathy Hanna, President of KPHA.
Good afternoon, and thank you, Chair Mosier. And is it on?
You're good now.
Okay.
Good.
Thank you.
Chair Mosier and committee members for allowing me to speak with you today. Again, my name is Kathy Hanna, and I'm here today as the president of the Kentucky Pharmacists Association to speak on behalf of Kentucky pharmacists across all practice areas and for the patients and communities we serve. The three largest pharmacy benefit managers, or PBMs, control just under 80% of the market and have touted record profits over the past several years. Meanwhile, Kentucky patients continue to pay higher prices at the pharmacy counter, and pharmacies are forced to accept declining reimbursements and the loss of their ability to care for patients due to patient steering, which occurs when PBMs mandate the use of mail order and PBM-owned or affiliated pharmacies. Policymakers from across the country are taking action, as several states have already passed legislation to regulate PBMs. And PBMs have faced increased scrutiny on the federal level related to their role in increased drug costs as well as anti-competitive practices. I'm here today to ask you to vote in favor of House Bill 457, which would address mail-order mandates and ensure Kentuckians have safe, reliable access to the brick-and-mortar community pharmacy of their choice. House Bill 457 protects a critical component of Kentucky's healthcare infrastructure, the community pharmacist. This is particularly true in rural communities where pharmacists are often the most direct and trusted provider contact for many individuals and families. A recent study that was conducted by the Public Policy Polling indicated that 84% of respondents do not support patient steering or mandatory mail order practices. Unfortunately, the services local pharmacists provide remain under constant threat from the harmful actions of major players in the healthcare system, most notably pharmacy benefit managers, also known as PBMs. PBMs play a significant role in deciding how Kentuckians access and how much they pay for medications at the pharmacy counter. You may have heard the argument that PBMs are looking out for patients, employers, and providers, and that this bill will significantly increase premiums. But based on Kaiser Family Foundation data, this has not been the case in states who have enacted anti-steering legislation. Furthermore, House Bill 457 provides additional protections for self-insured employers by requiring PBMs to act as fiduciaries and represent the best financial interest of our Kentucky employers. As frontline healthcare providers, pharmacists are all too familiar with the problems that PBMs are creating for our patients. I personally have witnessed countless situations where patients and their caregivers have been negatively impacted by PBM market practices, which often require or incentivize patients to utilize mail order or a PBM-owned or affiliated pharmacy. I would guess if you asked the pharmacist in your individual communities, they would tell you the same. These market practices rob patients of their ability to choose where they receive care and compromise patient safety, when medications are not shipped in a timely or safe manner, or a patient is deprived of the services they need. Pharmacy benefit managers and the harmful practices they use to generate profits put community pharmacies at risk. Every time a local pharmacy is forced to shut its doors, it is not only the patients that pharmacy serves, it not only hurts the patients that pharmacy serves, but it hurts the overall community, oftentimes in our most vulnerable rural areas. PBMs are quick to dismiss local pharmacy closures and say Kentucky pharmacists are doing fine. In my role as Vice President of Professional Affairs for American Pharmacy Services Corporation and as a practicing pharmacist, I speak with and work with pharmacists across Kentucky every day. I can tell you that pharmacies are struggling. In the past month, I personally know of 4 Kentucky community pharmacies that closed. That's in the past month, leaving 2 communities with no local pharmacy and forcing patients to either travel farther or switch to a mail-order pharmacy that lacks the one-on-one interaction, which is critical to ensure optimum care. Please help pharmacists across the Commonwealth continue to care for our patients and communities. I'm here today to ask you to prioritize Kentuckians, give people back their right to choose where they receive care, and put our Kentucky people over profits. Thank you.
Very good, and thank you very much for that. And I'm going to just briefly do some highlights of the bill, and then we'll take some questions if Dr. Bentley wants to jump in too. We can do that, or Representative Bentley, or both, right? House Bill 457 will prohibit pharmacy benefit managers from requiring patients to use mail order. They can still use mail order, just can't require them to use mail order, which are often owned and affiliated by the PBM itself. It requires pharmacy requirements to be imposed equally on all insurers in the same benefit category. We can get deeper into these weeds if you want, but I'll go down the line here. It establishes contracting requirements for pharmacy benefit manager contracts with pharmacies or pharmacists. And there's been quite a bit of overreach in these what we would call adhesive type contracts in the law industry. I'm sure they'll straighten me out on that in a minute, but they're basically take it or leave it contracts. There needs to be some flexibility there. I'm not sure this bill will provide it all, but it addresses it. This includes the prohibition of retroactive denials of pharmacy claims after adjudication. When you come to the register and you pay your medicine for your medicine, that should be the final cost, and everybody here should know what the final cost is, including the person selling it to you. But unfortunately, several months later, these guys have a habit of coming through and clawing back thousands and thousands and thousands of dollars. And some of that is Part D, federal Medicare. Some of it is different types of fees. And again, I can get into the weeds at some point if they want to, but we'll leave it at that. It prohibits pharmacy benefit managers from basing reimbursement for a prescription drug on outcome scores and matrix. I'm absolutely, on the surface you would think, I can't believe they wouldn't want that. The scores and matrix that were put together when all this came out several years ago seemed like a good idea, but what we've seen now is those metrics actually have nothing to do with these dispensing habits, and we found out, and they told us that if we did these outcomes, and I want to believe that they started out with 5, they've changed them 3 or 4 times, that there would be no additional fees. The idea would be if you do good, you wouldn't have any fees. Well, everybody did good, and the fees not only went from 3 to 5% 7 or 8 years ago that they said it would be, now they're on up to 10%. And they're just raking them back, and these pharmacies are closing.
Motion on
the second.
We have several motions. We have a motion on the bill and a second. Dr. Bentley, do you want to add just something quickly, and then we'll...
Very quickly, Chair Lady. Most people don't know my background, but I've been past president of the High Farms Association. I was on the board of directors of United Drugs in Phoenix, Arizona, which had 2,400 independent pharmacies. And I've had 31 years in a high university teaching pre-nursing and teaching pharmacology. But my point is that you committee and the state of Kentucky today will agree on one thing. The price of drugs and the price of gasoline you've never controlled. But today, committee, you got a chance. You can vote yes on this bill on the price of drugs. Thank you, Chair Lady.
Thank you very much. At this point, we have some folks who have signed up to speak, and I will invite folks who are here in person, if you could just come to the table together, and I will give you about the same amount of time that these folks had, just in fairness. But keep in mind that we do have a motion and a second. So, and then we also have online Mindy Farnsley, who you all can include in the discussion. Just please introduce yourselves for the record, and if you want to take a few minutes each, you can work it out. You're going to have about 10 minutes max.
Thank you, Madam Chair. Good afternoon, members of the committee. I'm Frank Jemley.
Is your microphone on?
Now it is. Thank you. Madam Chair, members of the committee, I'm Frank Jemley with the Kentucky Association of Manufacturers. I'll briefly express our concerns about the bill, and we appreciate the opportunity to appear before you. Our message is very basic. This is not the time to increase healthcare costs on Kentucky manufacturers and other Kentucky businesses. Now, I understand that reimbursement issues are debated continuously between pharmacies and PBMs, and this is not an issue that we manufacturers would ordinarily be involved with. But when we looked at the original bill, it had a very large cost increase component on businesses. Now, I have not been privy to the committee sub or the fiscal note for it, but our message is that in these extraordinary times, with inflation now at 7.9%, with prescription drugs already up an average of 6.6% across the country, with the effects of the pandemic still obvious to the economy, with the ongoing workforce crisis, and with the effects that are just now beginning to be felt from the war in Europe, this is not the time to raise healthcare costs on Kentucky businesses and Kentucky manufacturers. Representative Sheldon has been very gracious with his time, and we appreciate the dialogue that we have had with him. But we urge you to vote no on this bill if it does raise costs for businesses in Kentucky. Thank you, Madam Chair.
Thank you.
I'm Scott Brinkman, representing the Kentucky Association of Health Plans. And I just want to make one point, and that is relative to the contract provisions beginning on page 9 of the legislation. It is invariably a very tricky proposition when government, through legislation, defines the terms of a contract between two private entities. And it is for three reasons. One is it's very, very difficult to include all the material terms of a contract in legislation. It's hard to predict what a contract should provide, and that can oftentimes lead to confusion among the contracting parties as to what's permitted, what's not permitted. It can actually hamper the contractual relationship, creating inefficiencies. Second point is legislation is static, but the economy, society is dynamic and fluid, and it's very difficult to predict what innovations will occur, what best practices will emerge, what other changes in the relationship will develop over time. And so where the goal may be to create certainty and finality with in terms of defining the contractual relationship, the permitted contractual relationship between the parties, I would posit that one or both of these groups will be back to the table many, many times in the future seeking amendments to the legislation, to this part of the legislation, seeking to amend it, to refine it, to better define it. So I believe that this is going to be an evolving process, and to the extent certainty and finality is the goal, I think just the opposite will occur. And the third point I want to make is that this legislation is very, very limiting in terms of what that relationship, the contractual relationship, can look like. And basically eliminates a check and balance in terms of making sure that best practices and accountability are always observed. The reality is that through whether it's technological change, through changes in best practices, change in society ethos, mores, this legislation really does limit the ability to use tools, financial inducements, other tools to drive innovation, to drive best practices, to drive accountability. And you could have the perverse result of actually limiting the ability to pass costs, efficiencies, cost reductions onto people who pay health insurance premiums, who pay pharmacy costs. So I just caution the committee that take a hard look at the section of the legislation that sets out in very detailed terms the permitted parameters of the contractual relationship between PBMs and pharmacists, and ask yourself, are we actually creating a perverse incentive to drive in the future best practices, accountability, innovation within that contractual relationship? Thank you, Madam Chair, members of the committee.
Thank you, Madam Chair, members of the committee. I'm Rusty Kress here on behalf of America's Health Insurance Plans. Many of the elements that are part of House Bill 457 have been introduced in other states, but never, well, I won't say never, but very rarely in an omnibus bill. So even though we have concerns throughout the bill, just for the sake of time, we'll limit them to two. One of them deals with the concept of the elimination of the practice of white bagging. And Connor will go into much greater detail on that topic. But in essence, it's the use of specialty pharmacies for drugs that are administered in a clinical setting, not pills or anything like that. It's the drugs that you get infusions or things like that. Only one other state has enacted such a law, and that's Louisiana, and that was just last year. There have been bills proposed in many other states on the topic, but they haven't passed to date. The second issue relates to the accreditation standards in the bill. It says that PBMs cannot require pharmacists or pharmacies to impose more stringent requirements than the Kentucky Board of Pharmacy. Insurers believe that it's absolutely necessary to be able to go above and beyond Board of Pharmacy standards if that is their set protocol. So with that, Madam Chair, I will turn it over to Connor.
Good afternoon, Madam Chair, members of the committee. My name is Connor Rose. I'm with the Pharmaceutical Care Management Association. We're the national trade representing pharmacy benefit managers. Our members administer prescription drug benefits for more than 3 million Kentuckians who receive their health coverage through their employer, Medicaid, Medicare, and the individual market. We work with employers to help design benefits that employers are able to provide their employees with affordable access to prescription drugs. I would like to note we are the only entity in the supply chain whose goal is to lower and drive down the cost of those prescription drugs, and again, to make them as accessible and affordable as possible. We've heard from the business community that they are concerned about the cost increases associated with this bill. I haven't had the most time to go through that committee sub in detail, but I do know of a few provisions that I'd like to point out that on its face are cost increases and, again, limit the flexibility that employers should have in designing their benefits. But before I get into that, I would like to first note that if you recall in 2020, the General Assembly passed Senate Bill 50, which changed the way that the Kentucky Medicaid program used a PBM to administer prescription drug benefits. In that case, the state exercised its ability and the flexibility to contract in a way that best fits the state's needs and Medicaid enrollees' needs. However, House Bill 457 strips every tool away from employers and the flexibility that the state itself used in 2020. And those tools that are being stripped away across the board demonstrably reduce costs. Again, just to point out a few parts of the bill, as Rusty mentioned, something known as white bagging. So this deals with drugs that are administered in a clinician's office in a hospital. These are very high-priced drugs, and typically a hospital's pharmacy will provide that from their own inventory, known as buy and bill. However, hospitals are also marking up these drugs astronomically, on average probably about 250%. PBM specialty pharmacies can dispense those same drugs to the provider's office for administration for the patients at a cheaper rate. And so employers adopt these policies and support these policies and want these policies because they lead to lower costs. White bagging policies are a reaction to the exorbitant charges that hospitals mark up their supply of drugs. Secondly, I'd like to provide an example of what the words in the bill mean in practice. So this legislation prohibits any incentivizing of mail order pharmacies or lower cost channels. So let's say I'm an employer. I have 300 employees, say half of which are on statins for bad cholesterol. That maintenance drug can be provided through a mail service pharmacy at a significantly cheaper price than a retail pharmacy. If I'm an employer paying upwards of 80% of the total cost of care, I want to incentivize my employees to use the lower cost channel to obtain their prescription drugs. This would be prohibited under this bill. This bill prohibits our members, our companies, from offering lower prices to employers to provide benefits to their employees. I would also like to note that the state employee health plan is not included in this bill and not subject to any of these costly provisions for a reason. Secondly, I would also like to point out that if you look at the definition of PBM in the bill, it says if a PBM is contracted with a hospital that has a pharmacy and is self-insured, they are exempt from everything in the bill. And they wouldn't do that if they knew it wasn't going to increase costs, and it's going to. That's all I have for you. Happy to answer any questions. I think we have one more speaker.
Thank you. We are right at about the 10-minute mark, but I'll allow Mindy a minute or two, and then we'll take some questions.
Thank you, Madam Chairwoman and members of the committee. My name is Mindy Farnsley, and I'm a health insurance agent in Louisville, and I currently represent small to medium-sized employers. I'm also the current president of the Kentucky Association of Health Underwriters. Our job as brokers, we're intimately involved with carriers, pharmacy benefit managers, and employers to find the most cost-effective benefit plans to help employers be able to maintain their current health insurance policy, as well as retain and recruit employees, which is why I'm here today. I would like to start off by saying the Kentucky Association of Health Underwriters and most all agents and brokers fully support transparency in the healthcare and believes our industry needs more transparency. With that being said, we've spent many hours investigating House Bill 457, which is brought before you today, and in our expert opinion, this proposed piece of legislation does not do anything to address the cost of prescription drugs. In fact, it does the opposite. Not only do we think it's going to disrupt the current health insurance market and have a negative impact on the cost of health insurance premiums to employers and consumers, but it'll also remove critical cost containment strategies that we currently use to implement lowering healthcare costs for employers. In fact, one major carrier in Kentucky has already came out and said that they're estimating a 6% overall increase to healthcare premiums if this legislation is passed. At this time, with cost increasing everywhere for consumers and constituents of Kentucky, I just don't think that this is the time to pass legislation that's going to increase health insurance premiums any further. So on behalf of the Kentucky Association of Health Underwriters, I please ask that you oppose this bill, as it will negatively impact our clients and restrict the tools that we need to keep our health insurance costs down for Kentuckians. Thank you.
Thank you very much. I think at this point I would invite Representative Sheldon back to the table. I don't know if you want to stay nearby for questions. We do have a few questions. And I think most of these will, at least my question is referring to cost containment and providing options for patients. So Representative Sheldon, if you could just address the cost,
Some of them.
Yeah, the cost containment issue or the increased cost comments.
I would just say that anecdotally, you can pick any generic drug you want to and decide that 300 people couldn't get that drug for a certain price and come up with some assumption that the entire program is going to cost more. And that's kind of just doesn't hold water. I mean, the actual truth to all of this is that we took out most of any possible pricing issue. So I'm going to say there are a lot of tools that go in. I'm a self-insured employer. I have sat at the table with previous governors, with one of the men sitting at this table, and talked about the PBMs and what they did to the state Medicaid. This bill actually does a lot what we did in state Medicaid, and what we saw in our Senate Bill 50, state Medicaid last year, which they brought it up, was we saw an infusion in the economy in Kentucky of somewhere around $150 million, and we, after talking to Eric Friedlander, Secretary Friedlander last week, they're looking at a net positive gain. Now, how did that happen when in that bill we insisted that you paid $10.64 dispensing fee? In this one, we're not even mentioning that. So how did that happen? It can't be true now, because employers will have all kinds of control. It's called an RFP process. PBMs are just going to be forced to all act the same way. They just won't be able to. And by the way, let's just remember, you got insurance people up here and folks like that. They're being talked to by PCMA. Why? Insurance companies own the PBMs. Y'all do aware of that. There's the conflict of interest is absolutely, it's so vertically integrated, you know, and I won't go through and tell you which one owns which, but they know 75%. It's all insurance. So who's going to be against this? It'll be people that have something to do with insurance. That's what you've heard. And it'll be the PBMs, which is these guys. I fully expected that. This is what I'm saying. Patients have to be over profits. You can't sit here at this table in front of everybody at this committee and talk about cost. I'm an employer. I'm a consumer. And I wouldn't do anything to raise 16,000 employees in my company's premiums. I can assure you, we fired our PBM 4 or 5 years ago, and we put another one in, and we simply did an RFP process that has much of what this bill has in it. And we saved $2 million our first year. So they can talk all they want. The truth is, I've lived it, I see it, I know it. This is the truth. And I'll let Mr. Musser, if you don't mind, just finish it up if you want to speak to Whitebag, and made a comment about hospitals y'all were in the beginning, and there was a reason, there was a good reason. So why don't you tell this guy?
That's right. And I appreciate being given the opportunity to address it, because whitebagging is really an issue of patient health and safety. There is not the security of the prescription drug supply chain if you're using whitebagging. It means that instead of the patient receiving a drug there at the hospital that has been prepared specifically for the patient, it's being prepared by a third-party pharmacy, and it's being shipped by somebody. And if that drug then lands at the dock and it's not immediately put into cold storage the way it's supposed to be, if we don't know that it's there and that gets infused into a patient, that could be devastating. At the very least, it means that the patient isn't getting the treatment that they're supposed to get. There are timing issues. Often there have to be blood draws done before the infusion to make sure that all the indications are the same. And if that drug is not being compounded right there on premises and it's being shipped, there's going to be a waste involved of a very expensive drug. It's a case of, when you talk about what the hospital charges, that's a very alluring thing to say, that it's double the charges. But the bottom line is, you think about this, those of you who are providers, you already know, what's charged isn't what's paid. The insurer has a negotiated rate, and the negotiated rate is what is actually paid. So saying, it's an exorbitant charge, well, that's okay to say that, but what's actually being paid is the negotiated rate. And if they're unhappy with the negotiated rate, well, then there needs to be a new contract negotiated. I think that gets it.
If there are any more questions, I'll just kind of leave it at that. I tried to hit, we could talk about the contract issues, and Mr. Brinkman, I want to make sure I'm available to him to concern those contracts. We'll work through that, so I don't know that I need to speak a lot to that. There's some other things said, but yes, if there's
I
any
appreciate that. We do have a couple of questions. Representative Fleming.
Thank you, Madam Chair. Actually, I believe the answer was conveyed a few minutes ago about the white bagging and so forth. And I've always focused on what's best for the patient and making sure they're getting the best quality product, but also at the least expensive price. Question is, and I'm sort of data driven when it comes to going through what is beneficial to the patient, and I hear, well, we're going to save costs or it's going to increase costs, but I don't see where the rubber hits the road in terms of black and white on a piece of paper as far as what that go to pro forma. That's what I want. I haven't heard anything other than what Mindy said about 6% increase. Okay, it's great, but I haven't heard or I haven't received any information to help justify what you're saying, because I hear all this stuff. So if you could comment on that, I would appreciate it. And I do appreciate Representative Sheldon talking with the contract, because Secretary Brinkman brings up a good point that we need to be conscious of that. So I do appreciate your willingness to work with him on that.
Yeah, Representative Fleming, I'm happy to share this information with you. I'll be honest, this is from our organization, PCMA. Our head of research performed this analysis. We note our methodology, data sources, how we came to our conclusions. We are happy to see any scrutiny, anything. We are.
And
happy
has
to
this
address
been
that.
gone through an independent agency to go through and audit what both sides are saying?
No.
Then
No.
that's an issue to me.
Well,
because,
I would say
because you got to have justification what you're doing.
If we included the state plan, we could get a very accurate determination
Okay.
as far as what this costs. And I would say
Okay.
you're looking at least a couple million, $5-10 million.
Great. Thank you. Appreciate it.
Representative Prunty.
Thank you, Madam Chair. Connor, do PBMs have buildings? Do they have investment in product? What service do PBMs actually do? Is there brick and mortar besides just the office and the people? I mean, I'm talking about the pharmacists have the buildings, they invest in they have employees, they have product, they have to order the product. What service, literal service, do PBMs serve or provide?
Okay, well, quite a few actually. So on one hand, we manage and administer prescription drug benefits. So a part of that is we negotiate discounts with drug makers. They set the price of the drug. We are able to negotiate significant discounts off of those prices. Secondly, we manage pharmacy and build pharmacy networks. Whether that pharmacy network is narrow or broad is up to the plan sponsor or the employer. We employ a number of clinicians, nurses, pharmacists who are working with patients every day, especially when it comes to specialty drugs that are high-priced, complex, and they need sort of additional attention and care. So yes, I would say we're not paper pushers, the monopoly man in the back of the room laughing, pocketing all this money. We are out there working with patients, making sure they stay adherent to drugs, make sure they can afford their drugs, and make sure that they can go to pharmacies providing high-quality care at an affordable, low cost.
Madam, may I have a follow-up question?
Yes.
I understand. My understanding is that, you do the negotiation, and I understand why the Kentucky Association of Manufacturers might be concerned. But I would say manufacturers probably would want to get paid for the product they produce. And I think pharmacists just want to get paid for the service they provide. This is an issue, this is my 6th year here, and I've heard from my local pharmacists, many of them about to go under because of their issues with this. And I quite frankly am concerned that with all the things you took out, Representative Sheldon, if Ron Poole's going to be satisfied, because I've heard a lot of the issues he's told me about, you said you took out. So it sounds like there's still more work to be done. But I know my independent pharmacists have bought the buildings, they've employed the people, they've bought the product, they've got a lot invested, and I just think people ought to have a free choice. I gave up my choice for when I was working for the diocese. We could have had mail order, and I preferred to go to my pharmacist and get it from my pharmacist. So I appreciate that aspect of this bill. So,
well, to that point, even if an employer or a plan is trying to incentivize mail through lower cost sharing, that's going to be a lower cost to the employer. You still have the option to go to a retail pharmacy, whether it's a chain, independent. You might pay a little more, but again, the employer who's and health plans, insurers who are paying upwards of 80% of the total cost of the drug, the total cost of care, need to incentivize patients and individuals to go to low-cost pharmacies. That's how you keep costs low. That's how you are able to offer benefits. That's how you keep premiums low.
If I could comment on that, any willing provider law has been around for 20 years. It says that as long as a local pharmacy is willing to pay the same price and do it for the same amount, that they should be allowed to participate. Where these guys came up with the incentives was when they looked at that law and said, uh-oh, we can't send them to our own mail order people. We can't force people to go to these pharmacies we own so we can make more money. So they've created tiers and preferred pharmacies, things like that. That is where that came from. So they act like, well, we incentivize them to go. Well, you're doing that to try to get around the any willing provider law. We are absolutely willing to do it. And I've heard him say a couple of times that Kentucky State employees, if they were included in this, that he could give us all the data we needed. Well, they are included in this. And they have been included in this from day one. And we have a fiscal note that says it costs zero. Zero for our Kentucky State Health Employee Plan. Zero. Thank you.
Thank you. Representative Raymond. Representative Bentley, did you want to weigh in?
Yeah, when they talk about specialty drugs, I went to University of Kentucky and I have a doctorate in pharmacy. If I was trained well, don't you think I could do a specialty drug in my own pharmacy? If not, then we need to go back to UK and see what a degree a PharmD really is. A specialty drug means it takes extra care or temperature or something for a specific thing. But if I had the training, I can handle any specialty drug there is. On benefits, let them show you the data on positive income, positive outcomes on the data that PBM does for the state of Kentucky. And I can show you positive outcomes that come from the people of the state also. So that's what I want to say.
Thank you. Okay, now Representative Raymond.
Thank you. I wanted to quibble with a couple of things I heard. There's this consistent myth that we love our health insurance plans and we'd just be absolutely heartbroken if we left it for something better. I want to speak for just the everyman and say that is not the case. I also don't like to hear people say that what's good for employees is bad for employers and vice versa. When we know that what's good for one group is good for the other. I wanted to ask the gentlemen who represent the health insurance companies. The question is, will prices go up because health plans will raise them so as not to lose any profit?
I apologize, Representative Raymond. Could you please repeat that?
Will prices go up because health insurance companies will raise them so as not to lose any profit?
I sent to the committee, after I testified on Representative Moser's bill, at Representative Marzin's request, the dollar bill. I don't know if you saw that. I do not think that is the case.
Will you please tell me the health insurance companies that you represent and their profits last year?
I can't. It's America's health insurance plans. It's completely all the way across the country. I can't list them.
Billions?
But I don't know the answer to that.
Billions. Thank you.
Okay. Well, thank you. I just want to make a quick comment, and I appreciate all of the work that you've done, Representative Sheldon, Representative Bentley, everyone involved. I know that this is a big issue. The committee sub, I hope, is what everyone is working off of today, because it's vastly different than the first bill that was proposed. You know, I have a few concerns when I hear, and, you know, I've visited PBMs, I understand the services, but, you know, the cost containment and limiting options for patients, requiring the use of mail order and requiring the use of PBM-owned pharmacies is bothersome. I really feel like patients would like options. I think this gives them options. It doesn't force the issue. And I appreciate, Representative Sheldon, your willingness to continue talking about the contractual relationships and any limitations. I think maybe that might be a sticking point, but I think what we are seeing from other states who have implemented far more than this are cost savings. And I think I'll just end on that point. I don't think that I see, Representative Bowling, you have a question?
Yes, ma'am. A lot of these points, it's going to drive up costs. They've been talked about in here today, and some of them debunked. There's data from other states that have passed sections of this law that shows that the cost of health insurance actually fell after that. So there's good data to debunk those. One of the points talked about, and it's been brought up again, is the contractual relationship between two private parties. And as a provider, I'm going to tell you what that looks like. Here's your contract, sign it or don't. We don't care. And that's it. I can either sign it and sign up. There's 3 companies that dominate over 80% of the market. I can either sign it and have a part of that 80% of the market, or I can't. That's it. They don't care. I'm too small. There's a lot of small players in Kentucky, and that's what happens contract after contract. So I just wanted to address that point of it. Just wanted to address it. Thank you.
Could I make one quick comment to answer that?
One quick.
So
we do have a motion and a second, so.
Yes, just quickly. So independent pharmacies, we understand their importance in Kentucky. I am born and raised in Lexington, Kentucky. I got my COVID vaccine at an independent pharmacy in Lexington. We understand we need them in our networks for rural Kentuckians. That's on it. They are also not negotiating. It's not a David versus Goliath scenario. A large majority, about 80% of independent pharmacies in this state are a part of PSAOs who negotiate these contracts with PBMs on the independent pharmacy's behalf. Those PSAOs are owned by the 3 largest drug wholesalers. And you want to talk about billions, Representative Raymond, those wholesalers are all in the top 20 Fortune 500 list. So it's not this uneven playing field that the picture is being painted. And again, these independent rural pharmacies are very important to our networks. I would also like to say, just point out quickly, the National Community Pharmacists Association, they have the number of independent pharmacies in Kentucky. Kentucky has the most independent pharmacies in the state compared to every state it touches. So I just want to make that point clear. We don't want them to go out of business. We're not trying to force them out of business.
I appreciate that. Thank you. Okay, seeing no further questions, Madam Secretary, please take the roll.
Representative Bentley.
Yes.
Representative Bowling.
Yes.
Representative Bray.
Yes.
Representative Birch. Representative Dotson.
Briefly explain my vote. I had some circling of confusion, going back and forth, trying to depict what is real, what's not. And I appreciate your passion, Representative Sheldon, Representative Bentley. I trust you fully, and I give you a yes. Thank you.
Representative Elliott. Aye. Representative Fleming.
Aye.
Representative Frazier Gordon.
Yes.
Representative Marzian. Representative Gibbons Prunty.
Yes.
Representative Rayburn.
Yes.
Representative Raymond.
Yes.
Representative Riley.
I'll briefly explain my vote. I think all of us in here want lower prescription costs for the citizens of Kentucky. I think many of us are concerned about the squeeze on local independent pharmacies. Secretary Brinkman made a statement earlier, and I'm just paraphrasing. Don't quote that. There's many steps in this process, and there will be, and there's also many steps in the process in the legislature. Process number 1 is House Committee. We've had a good debate on here, and we're having a vote. Then there will be discussion before it becomes a vote on the House floor. Maybe amendments, maybe not. Then it will go to Senate Committee, and they will go through the same process, and they will go the same process on the floor. So there's going to be many steps in this process, and I'm looking forward to hearing all of those. My vote is yes.
Representative Sharp.
Aye.
Representative Sheldon.
Yes.
Representative Tate.
I briefly explain my yes vote, please. I sincerely appreciate Representative Sheldon and Representative Bentley bringing this before us. And as they have both alluded to, they have been working on this since 2018, 2019. And this has gone through 3 iterations. And again, I would just like to give a resounding, I trust you And I know that you have spent many hours explaining this to me, so I appreciate it. Thank you.
Representative Weber,
Yes.
Representative Westrom, Representative Wilner.
A brief comment. The trust on this issue and the two of you bipartisan, yes.
Chairwoman Mosier.
Yes, ma'am. Okay. House Bill 457, as amended by the committee sub, passes with favorable expression, and the same should pass on the House. Thank you very much for all the great debate. Thank you.
Congratulations.
All right, seeing no further business to come before the committee, and I see people walking out, we are adjourned.